You are in the meeting now. Oh, I was muted. Can you hear me okay?
I can hear you. Can you hear me?
Yes.
It said the host password wasn't working, so I just logged in with the participant password.
That's fine.
One sec, I'll share my screen. You see my screen okay?
Yeah, it looks good to me.
Okay.
I think we'll give people just a couple more minutes to arrive before we get started.
I've got a meeting. Good morning. Hi, James.
Hello?
James, hi. Louis, how are you?
Oh, hi, Louis. I'm good. How about you?
Not bad. We meet again in BC, huh?
I didn't know you were in BC.
I sent you an email 2 weeks ago.
Oh, I didn't get it. Which account did you send it to?
Gmail, I think, or something.
How are you?
I'm good, good. I'm in Sunshine Coast, if you know.
Oh, very nice.
How's things?
We're pretty good.
Family is good?
Yeah, everyone's good. The usual.
You like it here more than Fredericton? Or St. John?
Advantages to both. Depends on the day.
Good, good. Well, I'm glad you are here, so.
Nice to hear from you.
We can send you patients from here.
Sounds good.
Okay.
I think we're going to get started. We're a couple minutes past 7:30, so just out of respect for everyone's time. So I want to welcome everyone to this week's iteration of our OB-GYN and neonatology grand rounds. We've got a special talk today, which I'll get to in a moment, but I just want to remind everyone to please mute your mics and turn off your video during the course of the presentation, and we can reserve questions for after the talk. Also, please remember to submit your attendance and evaluations for your CME credit. And on that note, I would like to introduce a colleague and friend of mine, Dr. James Andrews, who's a consulting subspecialist in maternal-fetal medicine who's been working for Fraser Health for the past 2.5 years. Prior to joining the Fraser Health team, he was working in New Brunswick for 7 years with a practice in obstetrics and maternal-fetal medicine. Dr. Andrews completed his residency and fellowship training at Dalhousie University, and he has a clinical interest in fetal echo as well as fetal growth restriction, and is currently involved in guideline development, especially in provincial guideline development with respect to fetal growth restriction. And he'll be giving us a talk today on fetal growth restriction. James, I'll leave the podium to you.
Thanks, Jason, for the introduction. So I'm going to talk about fetal growth restriction. It is a huge topic. I tend to talk quickly, so we'll try to get through some of this material. And of course, if there's questions, I'd be happy to answer what I can at the end. Let's see if this will work. Okay, so I'll skip the outline, and we'll just kind of dive into some of the information here. So as we all know, fetal growth restriction refers to a fetus that has failed to achieve its genetically determined growth potential. We're concerned about it because it's associated with an increased risk in perinatal morbidity and mortality. There are a number of different pathways that lead to the end manifestation of growth restriction, usually as a result of suboptimal fetal nutrition and uteroplacental perfusion. It's relatively common. It affects 3 to 9% of all pregnancies, and it's more common when it's in late presentation. I'll go over the different phenotypes of growth restriction in a few slides as well. So an important aspect of prenatal care that we're all involved in is trying to identify and manage pregnancies that are affected by fetal growth restriction. We all spend a lot of time doing this in our practice. Small infants or small for gestational age infants that are identified and managed before birth have a 4 to 5-fold reduction in mortality and or severe morbidity. So therefore, it's really important to try to identify these patients so we can monitor them and potentially intervene to improve outcomes. On reviews, it appears that small fetuses comprise about almost half of all non-anomalous stillbirths, and most of these are not recognized before birth. So therefore, this does make up an important aspect of prenatal care and trying to recognize these fetuses that are at risk. I won't go through this slide in detail, but this just highlights some of the different etiologies of fetal growth restriction. We can look at uteroplacental perfusion, where there's reduction of nutrition being delivered to the fetus. That can be a result of maternal factors, placental factors, or umbilical cord factors. And then there can also be inherent disorders in the fetus itself that can lead to growth restriction.
Yeah. Why are they still here?
In terms of risk factors for growth restriction, there are a number, and this list is not comprehensive, but we can kind of divide them into history-based risk factors, which we can ask our patients about, looking at their maternal background, medical conditions, a common one that we see being chronic hypertension and chronic kidney disease. Their obstetric history, both current and prior. We can look at biochemical markers in areas where they have access to placental growth factor. A low PLGF can be a risk factor for growth restriction. Low PAP-A has been associated with growth restriction, and a high alpha-fetoprotein as well. And then, of course, some of the screening markers that we look for in ultrasound, looking at Doppler velocimetry of the umbilical artery. I think I wrote uterine artery twice, but one of those should be umbilical artery, uterine artery, and multi-vessel Doppler interrogation. Risks associated with growth restriction, the ones that we're looking for antenatally, that risk for stillbirth. We know that with abnormal placentation, there's a risk of maternal presentation of preeclampsia. There are higher risk for placental abruption and preterm birth as well. In the short-term neonatal period, there's an increased risk for neonatal mortality as well as morbidity. And long-term, there's an increased risk for neurodevelopmental disorders and metabolic syndrome. So how do we define SGA and FGR? These terms are often used interchangeably, but they do mean different things. One of the challenges that different societies, different countries, and different experts actually use these terms, and they have slightly different meanings depending on where you're practicing and which reference you're using. So for our purposes, we're going to call small for gestational age as a fetus with an estimated fetal weight, or EFW, or abdominal circumference below the 10th percentile for gestational age. And fetal growth restriction, the simplest definition is really a fetus that is not growing to its potential due to pathologic process. So it's a nice simple definition, but often hard to classify. We're moving away from the term IUGR. It really doesn't make sense to call it IUGR. That refers to a location, so we might as well just talk about the fetus because that's what we're worried about. So fetal growth restriction is the more contemporary term that you see in all the new guidelines. The challenge that we have with defining fetal growth restriction is that there's no universal consensus for defining or for managing growth restriction. We use percentiles to define growth restriction in SGA, and this is problematic. It's an easy thing to do, but it does miss some fetuses that are actually growth restricted. Growth restriction is not synonymous with SGA, although a lot of people will use those terms interchangeably. But we have to keep in mind that not all small fetuses are growth restricted. And depending on which study you look at, about half to two-thirds of them are actually constitutionally small and not growth restricted when they're under the 10th percentile. And likewise, not all growth-restricted fetuses are necessarily small. It is certainly possible to have a fetus that plots at the 20th centile on the growth curve that is actually growth-restricted because that fetus may have a potential to be at the 80th percentile if there wasn't a pathologic process. And that's a group that we have a lot of difficulty identifying because we're using percentiles to look for growth restriction. Kind of illustrating the challenges with defining growth restriction, it was a study that came out in 2018 that kind of did a poll internationally looking at classification around the world for both SGA and for growth restriction. I'm not sure if you can see my pointer, but over here in New Zealand, for example, they use, for growth restriction, they use an estimated fetal weight less than the 10th centile. They use customized centiles to that patient, or an abdominal circumference below the 5th percentile, so they differentiate between the abdomen and the estimated fetal weight. The Canadian guidelines are outdated at the moment. They're currently under revision, but from 2013, the Canadian guidelines from the SOGC classify growth restriction as an EFW less than the 10th centile or an AC less than the 10th centile. And in the US, they, until recently, they were just looking at the estimated fetal weight below the 10th centile. This does pose a lot of challenges for research as well, because if we're not talking the same way or classifying the same way, it becomes hard to compare studies and to compare protocols. So in recognition of the challenges that this provides, a group of international experts kind of came together and they published a consensus definition in 2016 using the Delphi procedure. I believe just over 50 or so experts from around the world were involved initially, and just under 50 completed the entire procedure. They came to the conclusion that we should move forward with this definition for now until further evidence is forthcoming. They separate fetal growth restriction into the two known phenotypes: early onset growth restriction, which generally occurs prior to 32 weeks gestation, and late onset growth restriction, which we generally recognize at 32 weeks or above. So if we kind of break this down a little bit, to be diagnosed with early onset growth restriction, you can be fairly certain of your diagnosis if the AC or the EFW is below the 3rd centile for gestational age. For those that are between the 3rd and the 9th centiles, you need an additional factor to try to differentiate being constitutionally small versus being growth restricted. So for example, the elevated uterine artery pulsatility index on the maternal side, or an elevated umbilical artery pulsatility index over the 95th centile. Their goal here is to try to separate out the low-risk SGA fetus from the growth-restricted fetus. If we look over at the late-onset growth-restricted fetus, they still use the same criteria for AC and EFW being below the 3rd centile, and then, of course, between the 3rd and the 9th centiles, you need an additional factor. So again, biometry being less than the 10th. They do have a kind of decreasing growth velocity, and there is a criterion where the AC EFW crosses centiles, so 2 quartiles or 50 centiles on a growth curve. This is probably the most controversial aspect in their group that they had the least amount of consensus on. And then Doppler findings, so cerebroplacental ratio, which I will talk about a little bit later on, below the 5th centile for gestational age, or an elevated umbilical artery pulsatility index over the 95th centile. So again, their idea was to try to have some consensus and some uniformity going forward to help guide research and to maybe come to more, provide more conclusive evidence on how to monitor and manage these pregnancies. So we use the 10th centile because we know that a fetus with a birth weight below the 10th centile is at increased risk for stillbirth and perinatal mortality. We also know from multiple studies that fetuses that are below the 3rd centile are at the highest risk, and this risk remains high irrespective if the Dopplers are normal or abnormal. Because of this, the AC or the FW below the 3rd centile is used as an isolated criterion to diagnose fetal growth restriction at any gestational age in the more contemporary classification. This is a study that looked at over 3 million birth outcomes in the U.S. This was based on postnatal weight, so there are some biases in it. But what they tried to demonstrate was the risk of fetal death based on percentile. And you can see the top curve is those that were less than the 3rd centile, which there's a higher rate of fetal death, particularly starts to increase as you approach the 37-week mark. And in comparison, you can look at those between the 3rd and the 5th, 5th and 10th, and then those over the 10th. This was kind of results from a population study out of Scotland that looked at just under 1 million births, and they were looking at the risk of term perinatal death by birth weight percentiles. And again, we can see that the 1st to 3rd percentile, the odds ratio for perinatal death is quite a bit higher, approaching 10. It's still high at the 4th to the 10th centiles, but one thing that I think we should recognize is that the 11th to 20th centile still has about twice the odds of perinatal death compared to those that are over the 20th centile. So I think it's important to realize that, a baby that plots at the 11th centile, isn't necessarily that different than a fetus that plots at the 9th centile. And we do have to have a cutoff somewhere, but there is a spectrum in terms of morbidity. From this study, actually, the lowest risk is at the 75th to 80th centiles, not the 50th centile, when they kind of dive into their numbers a little bit more. And then I really like this pictograph because I think it illustrates the problem that we have at the moment with identifying growth-restricted fetuses. So kind of in green, we have the appropriately grown fetus, which makes up a large proportion of fetuses in our population. There's going to be a certain proportion that measure large for gestational age over the 90th centile and a certain proportion that measure small under the 10th centile. These two groups are easy to recognize if an ultrasound is performed looking at biometry and plotting them on the growth curve. Within that, we have growth restriction that overlaps all of these three groups. Again, easier to recognize if we can identify the group that's small. We know that approximately half of those will be growth restricted. But what's really hard to identify is the growth restricted group that's actually plots in the appropriate range when we do a growth assessment. This is a group that largely we don't identify and probably makes up a significant proportion of unexplained stillbirths. Right, so we'll talk a little bit about some management principles. So the management of growth restriction is based on early diagnosis, optimal fetal surveillance, and timely delivery with a goal to reduce perinatal mortality and minimizing morbidity. In pregnancies complicated by growth restriction, delivery decisions require balancing the risk of prematurity against the risk of stillbirth with ongoing gestation. These are decisions that sometimes are difficult to make depending on how early the patient is and how small the fetus is and the clinical context. Decision to deliver is guided by both maternal and fetal factors. Sometimes you have no choice but to deliver for maternal safety. And we'll talk about some of those criteria as well. And there's currently no universal consensus on the best approach to manage growth restriction. The Truffle study, which I will talk about as well, that came out 2013, I believe, is when it was published. They used a standardized protocol to diagnose and manage early onset growth restriction, and they demonstrated a significant improvement in outcomes. And so it appears that a protocol for the diagnosis management is preferable. So part of our prenatal care is to detect growth restriction prenatally so that we can have an opportunity to monitor these pregnancies, to offer intervention, and to reduce, to improve outcomes. And improving detection of growth restriction is an important strategy then to reduce stillbirth. The problem with this is that if we overdiagnose or overcall growth restriction, we can lead to unnecessary parental anxiety. I think we're all guilty of causing that at some point. Overdiagnosis or overcalling can also lead to unnecessary costs of the healthcare system and potentially harmful interventions if we decide to deliver prematurely that didn't need to be delivered. In terms of screening, history is always important. We can ask our patients about risk factors, maternal, fetal, and placental risk factors. It's really important that we establish an accurate due date because that's what we're going to use to reference the pregnancy. We're all familiar with doing symphysis fundal height measurements as a primary screen. It is useful. It's not the best way, but it's pretty economical and pretty consistent. And of course, if there's any aberration from the symphysis fundal height, that can lead to an ultrasound assessment to assess fetal growth, the amniotic fluid volume, and well-being. Other investigations you can consider would be serum markers. There's actually no indication to do serum markers as a screening tool on its own, but if serum markers are available from aneuploidy screening, then sometimes they can give some insight into placental function. At some point in the near future, we're likely going to be looking at using placental growth factor as a screening tool. And then uterine Doppler velocimetry, particularly if it's done in the first trimester, can be really helpful for screening. So accurate estimation of the due date is really essential. If we're establishing the due date, all of our references are going to be based on that due date. So if we're inaccurate on the due date or off on the due date, we may classify a fetus as growth restricted that actually is normally grown, or we may reassure ourselves that a fetus is normally grown when in fact is growth restricted. So having accurate estimation of the due date is really important. It's also important to keep in mind that there are lots of different growth standards and growth reference charts that are available, and a fetus that may plot in the normal range on one growth chart may plot in the SGA range on a subsequent growth chart. I won't go into this that much more, but Dr. Liao from Vancouver has been looking at this with the thought to move the province onto a new growth standard. This is a nice little table in a study that was published recently outlining how a small error in the measurement of fetal crown rump length can affect growth measurements. So if we just look at the first column over here, if we have a fetus that is on the 10th percentile, that would be the true estimate of fetal weight. If the crown rump length is over measured by 2 millimeters, that fetus would actually plot at the 5th centile at 20 weeks, versus if it's under measured by 2 millimeters, that fetus would plot at the 17th centile, when again the true centile would be the 10th centile. Measurement errors of 2 millimeters are actually quite common with first trimester dating, so it's important to keep in mind that accurate dating is really important and can have a pretty significant impact on how we classify growth later on. There's a lot of talk recently about routine fetal growth assessment in the third trimester. There was a study that looked at just under 4,000 women to compare the detection of a small for gestational age infant by routine ultrasound in the third trimester versus clinically indicated ultrasound like we're practicing now. They almost triple the detection of almost triple the detection of the small for gestational age infant by using this approach. At the moment, there's no current evidence that this would actually improve outcomes, but a lot of research is ongoing in this area, including a follow-up to the truffle study looking at growth restriction after 32 weeks gestation. So I think this is something that we may see being recommended at some point in the future, but at this time there isn't evidence to support it in terms of improved outcomes. So when a small fetus is found, kind of the initial things that we think about is having a look with ultrasound, doing a detailed fetal anatomic screen. Up to 20% of cases are associated with fetal structural or chromosomal abnormalities, and they're looking at a multi-vessel Doppler studies in the fetus. For early onset growth restriction, we would consider genetic amniocentesis in that population. There's an up to 5% risk of finding a abnormality with microarray. This is particularly increased if there's anomalies that are found at the time of the anatomy scan, or if there's polyhydramnios present as well. And then congenital infection is also associated with growth restrictions, so we would consider screening for CMV toxoplasmosis or syphilis if there's risk factors. One of our main tools to assess and to manage these pregnancies is ultrasound. We can do biometry. With that, we can calculate estimated fetal weight. We can have a look at the placenta, how it's developed, assess the amniotic fluid volume. We can look at blood flow in several fetal vessels. Ones we look at for fetal growth restriction would be the umbilical artery, middle cerebral artery, ductus venosus. We can also look at the maternal side, looking at uterine artery Doppler velocimetry. And we can do a biophysical assessment as well. So with Doppler ultrasound, we're just taking advantage of the physics of the sound wave that can allow us to visualize moving particles like blood cells in a blood vessel. We can generate a color map so we can see the blood vessel. We can then measure the velocity of blood flow and plot it over time to generate a spectrograph over here, which we can then use to analyze and determine resistance in disease or impedance to blood flow within a vessel. And we can use that to assess the well-being of a fetus. So with Doppler, we're looking at the vessel, we're assessing the waveform both quantitatively and qualitatively. And one of the things that we will calculate is resistance indices or assessment of impedance. There are three that are commonly reported: pulsatility index, resistance index, and the SD ratio. In the community, you probably most often see SD ratio come up on the ultrasound scans. We look at pulsatility index. That's what's commonly reported in the literature. The pulsatility index doesn't approach infinity like the SD ratio does when you start to get absent flow. It's what's preferred, and eventually there's going to be a move to have the peripheral units report pulsatility index as well. These are essentially all just different ways of calculating resistance or impedance to blood flow within a vessel. So in this talk, I'm going to be referring to pulsatility index when I'm talking about resistance. So we look at the umbilical artery. It's one of the main vessels that we look at. With Doppler, we can assess the impedance of blood flow from the fetus to the placenta through the umbilical artery. This gives us the hemodynamic aspect of placental dysfunction. Impedance decreases as gestation progresses, so we do have graphs that we can plot it on our tables to look to see where that resistance plots for that gestational age. Using umbilical artery Doppler in the management of high-risk fetuses has reduced perinatal death. It's in all of the recent guidelines that come out in terms of managing and monitoring fetal growth restriction. We can quantify umbilical artery blood flow by looking at the pulsatility index objectively, or by visual description of the end diastolic flow. So this kind of just shows the kind of the range and the progression of abnormal Dopplers. Seems like my emojis have changed. I'm doing this on the work computer from my Mac, and things didn't transfer over quite the way that they were supposed to. But anyway, this graph over here shows increased impedance with a PI greater than the 95th centile. Essentially, we're looking at the difference between the systolic flow versus the end diastolic flow. As there's further deterioration in the placenta, so actually before I go on with that, to get to this point where you have high resistance, you generally have to have about 30% of the placenta that's damaged. Once you get to 50 to 70% of the placenta that's damaged, we get more advanced or late Doppler changes. So here we have absent end diastolic flow. So there's a point in the blood vessel in the umbilical artery where blood comes to a standstill and is not moving forward. And then as disease worsens, we get little episodes of reversal of flow where blood will actually flow back toward the fetus for a brief period of time. So this is certainly worrisome for hypoxia, acidosis, and reduced cardiac compliance. And depending on the gestational age, these would be indications for delivery. So the degree of placental blood flow resistance is really the primary factor that we use to determine the rate of progression. We can use the umbilical artery to help kind of predict progression and use this for determining monitoring intervals in the fetus that's growth restricted. If we look at fetuses that have an elevated pulsatility index, median time to additional surveillance abnormalities is generally 2 weeks. It's often longer than that. With absent end diastolic flow, the median time to further deterioration is about 5 days. And then reversed end diastolic flow, the median to further deterioration beyond that is approximately 2 days. And this just illustrates how resistance in the umbilical artery by pulsatility index declines over time. Okay, another vessel that we can look at is the ductus venosus. That's the little shunt that comes off the umbilical vein towards the IVC, bypassing the liver, so bringing in highly oxygenated blood flow from the placenta. Doppler abnormalities in the ductus venosus waveform reflect advanced stage of fetal compromise. This is quite worrisome when it's seen. It's a venous waveform, so we have kind of 3 peaks here. And what we're looking at is the A wave. This is formed by when the atria contract, there's pressure put down the venous system and it causes a reduction in blood flow. The normal fetus, there should always be positive flow in the A wave. With progressive deterioration, we start to see a deeper and deeper A wave trough to the point where there's absent flow or reverse flow. And when we get to those kind of end stage ductus venosus changes, there's a high risk of mortality, and it's often an indication for delivery. Over here, this is the ductus venosus coming in over here. I'm just going to play the clip again, if it will. Again, I'm using a stupid Microsoft computer, so it's not playing. I apologize. One of the things that we have to be concerned about is making sure we're assessing the right vessel. So in general, if there's a pregnancy being managed based on ductus venosus, it really should be managed by maternal-fetal medicine. There's a lot of other veins that kind of come into the IVC, which is over here. Those hepatic veins and the IVC normally have a reversed A wave. So if the wrong vessel is interrogated with a Doppler, then it could be reported as a ductus venosus with reversed A wave. And there certainly have been circumstances where a fetus was delivered because the wrong vessel was interrogated. So it's important to kind of understand the anatomy and to ensure that the proper vessel is being looked at. So this just shows the progression of ductus venosus abnormalities. We have a nice positive A wave over here. These are some early DV changes where we have a deep A wave trough. We can measure a pulsatility index for veins in the ductus venosus, and if it's over the 95th percentile, that'd be considered abnormal. And then we get the late changes where you have an absent, or in this case, you can see reversed flow in the A wave. Right, so middle cerebral artery is another one of the fetal vessels that we look at. It's the largest vessel in the fetal cerebral circulation. You can see both MCAs coming off the circle of Willis over here in this clip. If there's fetal hypoxemia, it results in cerebral vasodilation, which causes resistance to decrease and flow to increase in the brain, which is a so-called brain-sparing effect in its normal compensation by the fetus. It does reflect placental dysfunction, so it is a worrisome finding when seen. So kind of opposite to the umbilical artery, where we see in the umbilical artery we see an increase in resistance with growth restriction. In the MCA we see the opposite, where we see a decrease resistance pattern develop. And so we would call that abnormal if the pulsatility index is below the 5th centile for gestational age. So some of you may see on our reports the CPR, or cerebroplacental ratio. This quite simply is a calculation where we take the pulsatility index from the middle cerebral artery and divide it by the pulsatility index from the umbilical artery. A low CPR is abnormal. There's lots of different reference ranges for that, or you could just use a cutoff of less than 1, which is what we are considering. This actually becomes abnormal prior to overt abnormalities in the umbilical artery or middle cerebral artery vessels themselves. So a low CPR indicates a redistribution of blood flow of the cardiac output to the brain, similar to the middle cerebral artery. So it indicates brain sparing. And it would be an early marker of hypoxemia. It's also associated with poor perinatal outcome. So if you have a low CPR in SGA fetuses, there is an increased risk of stillbirth, perinatal death, low APGAR score, neonatal acidosis, NICU admission, as well as intrapartum compromise and need for cesarean section. There's also a risk of adverse outcome in appropriately grown fetuses with a low CPR, but that association is much less. On the maternal side, we look at the uterine artery Doppler. We know that the placenta, when it's developing normally, will cause spiral arteries to remodel from a high resistance to a low resistance waveform. With abnormal placentation, that remodeling may not occur, and we can see persistence of the high resistance pattern. And so we can use it as a tool for screening. In some cases as well, when we have a small fetus in front of us, we can look at it to see if it's abnormal to help with the diagnosis of IUGR, particularly from a placental mediated cause. Okay, so other monitoring tools, we have a non-stress test, NST or cardiotocography, CTG, refer to the same thing, just different nomenclature. A normal or reactive NST virtually excludes fetal hypoxemia. In Europe, they commonly have access to a computerized CTG or CCTG. In this instance, they have a computer that analyzes for short-term variability, and then it provides an objective assessment of what that STV or short-term variability is. So in the presence of hypoxemia or hypoxia, we know that there's alterations in the sympathetic and parasympathetic activity in the fetus, and that results in a reduction in the fetal heart rate variation or reduced STV. There have been studies, including the Truffle study, that was a high-quality study that used CTG for fetal surveillance, and it does provide pretty reasonable information in terms of fetal status with respect to hypoxemia and acidemia. Visual inspection of the conventional CTG or the NST like we're doing does not provide the same information. There's a lot of inter-observer differences in assessing the NST by eye. So conventional NST can be performed as a standalone test. Sometimes it's performed with an assessment of amniotic fluid volume, which is called a modified biophysical profile, or it can also be performed as part of a 5-component biophysical profile. The fetal heart rate pattern reflects fetal oxygenation acid-base status at the time of evaluation. So it does not predict deterioration like we do get with umbilical artery assessment, It tells you how that fetus is doing at that point in time. In unselected pregnancies, the rate of stillbirth following a normal NST is 1.9 per 1,000. A non-reactive NST, I know that's old terminology, but essentially if there's no accelerations, it does have a low specificity for hypoxia. And in this situation, most experts would recommend additional testing to determine fetal status. Reduced variability is a stronger prediction of hypoxia compared to lack of acceleration. The last tool for assessment I'm going to talk about is the biophysical profile. The biophysical profile is a score based on assessing with ultrasound fetal tone, gross body movements, breathing movement, amniotic fluid volume, and heart rate reactivity. Sometimes the NST is not performed. If a factor is present, you're given 2 points, so you're scored either out of 8 if there's no NST or out of 10 if there is an NST. Abnormal biophysical profile is a late manifestation of placental disease. It generally becomes abnormal about 48 to 72 hours after ductus venosus Doppler abnormalities are present in the majority of cases. There have been studies that looked at a BPP score in association with fetal pH, and if it's less than or equal to 4, it's an associated fetal pH of below 7.2. And if there's a score of 0 on the biophysical profile, there's basically sensitivity 100% for predicting fetal acidemia. This correlation actually remains high if you're using modified biophysical profile compared with the 5-factor profile. So in unselected pregnancies, the rate of stillbirth in the week following a normal biophysical profile is 0.8 per 1,000. The BPP, much like the NST, tells you how that fetus is doing at that point in time. It's not useful for prediction of deterioration. But there has been kind of documentation of the sequential loss of BPP components with worsening disease from a reduction in heart rate reactivity, loss of fetal breathing movements, then gross body movements, and then tone. Coming down the road are some novel biomarkers, placental growth factor and soluble FMS like tyrosine kinase. The first is pro-angiogenic, the latter is anti-angiogenic, and if there's an imbalance in this ratio, it may indicate that there's placental insufficiency, so this may be useful to diagnose growth restriction. I think more likely we're going to see placental growth factor being used. It's already being used for screening, but it also may be used for diagnosis as well and trying to differentiate the cause of growth restriction, and that's likely something that we're going to see in the near future. Right, so we'll talk about phenotypes of growth restriction. So early onset, often associated with maternal vascular malperfusion of the placenta. This leads to abnormal transformation of spiral arteries by the trophoblast. You get pathologic features of placenta villi, multifocal infarction, placental insufficiency, and then growth restriction. This is kind of the classic diagram that Ahmed Bashat published several times, kind of illustrating the vascular responses and behavioral responses that we see with early onset growth restriction. Early onset growth restriction generally follows a predictable pattern. So initially, the first indication is an elevated umbilical artery pulsatility index. Brain sparing is usually not seen until a little bit later on, and the ductus venosus is normal in the early stages. With worsening disease, we start to see absent flow in the umbilical artery, start to see evidence of brain sparing. That A wave in the ductus venosus becomes steeper. As things get worse, we start to see reversed flow in the umbilical artery. We'll start to see absent or reverse flow in the A wave, and then as some of the late features, we see loss of behavioral aspects on the biophysical profile, which then precedes fetal death. Late onset growth restriction is a very different entity. It's much more difficult to recognize. There's either milder placental lesions or just may involve alterations in diffusion of oxygen and nutrients across the placenta. We don't often see umbilical artery Doppler abnormalities in late onset growth restriction. The most common Doppler abnormality that we would see would be a low middle cerebral artery pulsatility index or a low cerebral placental ratio. And this does make it much more difficult to identify. So again, going back to Dr. Bashat's kind of diagram, kind of illustrating the difference with late onset growth restriction, the vast majority of these fetuses have a normal cord Doppler, and that will persist all the way through. There is a small proportion that will have an elevated pulsatility index, but the majority of them have normal cord Doppler. What we're more likely to see is a decreasing cerebral placental ratio over time. We may see brain sparing. That tends to be a late finding with late onset growth restriction. And then, of course, we can start to see loss of some of the behavioral aspects towards the end, which precedes fetal death. So this kind of illustrates the differences between early onset and late onset growth restriction. With early onset growth restriction, our main challenge is management. We often have a small fetus that's preterm and trying to decide when to deliver this fetus. Our main challenge with late onset growth restriction is detection. We can't rely on umbilical artery Doppler to detect this. It's a much more difficult entity to diagnose. Early onset is less common, about 1% of pregnancies, whereas late onset growth restriction is more common. It's easier to identify early onset growth restriction as well because the fetus is usually quite small, whereas late onset growth restriction, the fetus may not be small. There's a high association of preeclampsia with early onset growth restriction, and although preeclampsia can develop with late onset growth restriction, it's much less common with that pathology. Okay, so I'm going to talk about a few studies, and then we'll get into some of the recent guidelines. In 2003, the growth restriction intervention trial was published. It's commonly cited as one of the main articles looking at management for growth restriction. They looked at pregnant women with fetal compromise, which was loosely defined as abnormal biometry or abnormal cord Doppler between 24 and 36 weeks gestation. They really didn't talk about how they managed these pregnancies or how they monitored them. Their intervention was immediate delivery or delivery when there is no longer uncertainty about how to manage the pregnancy. They looked at 547 women and found no difference in outcome, and essentially what you can take home from this is that in the absence of specific criteria, either management approach resulted in the same perinatal outcome. So if you deliver too early, then you're going to have, more likely to have preterm complications and a neonatal death. If you wait too late, you're more likely to have a stillborn fetus. The DigiTrat trial was published in The Lancet in 2010. They were looking at comparing the effective induction of labor with a policy of expectant management and monitoring for growth-restricted fetuses near term. This was done in the Netherlands between 2004-2008, and they looked at fetuses that were over 36 weeks of gestation with suspected growth restriction based on an AC or EFW below the 10th centile or flattening of the growth curve, which was not specified on how that was assessed. It was up to the physician at that time. They looked at 321 women. Their primary outcome was a composite measure of adverse neonatal outcomes, and they found no differences in obstetric neonatal outcomes between the two groups. However, deliveries that were prior to 38 weeks resulted in a higher rate of admissions to the neonatal intensive care units. So what this indicates is that if we're going to deliver prior to 38 weeks, it's probably need to have another reason besides smallness. And you'll see that in some of the recent guidelines that are out there. Probably the highest quality study that's been done at this point is the Truffle study that was done in Europe, the trial of randomized umbilical and fetal flow in Europe. This was published in 2013 in the White Journal. It describes perinatal morbidity and mortality following early onset growth restriction based on time of antenatal diagnosis and delivery. Prospective multi-center study done in 20 European centers. They looked at singleton fetuses between 26 and 32 weeks of gestation. And the fetus had to have an AC below the 10th centile and an umbilical artery pulsatility index above the 95th centile. They randomized into three groups, those that had reduced short-term variation on computerized CTG. The second group is early abnormalities of the ductus venosus waveform, so pulsatility index for veins over the 95th centile, or late DV changes where they saw absent or reversed A wave. They then had safety net criteria for delivery based on the maternal indication or clear CTG abnormalities, and these are their safety net criteria. So we don't have STV criteria here because we don't use CCTG for monitoring pregnancies, but these are the cutoffs that they used, and that would trigger delivery if any of those safety net criteria were met. For Doppler criteria, if there was reversed end-diastolic flow and they were 32 weeks or beyond, they would deliver. If there was absent flow and they were 34 weeks or beyond, they would deliver. Although they did allow for earlier delivery based on local policies. So when they looked at this, they found that when they restricted their analysis to surviving infants, there was a statistically significant reduction in the group that was randomized to late ductus venosus changes. And this kind of illustrates the proportion of without neurologic impairment at 2 years. What they found is their outcomes were better than expected by using a protocol to manage these pregnancies. Over 80% of infants survived and had no neurologic impairment at 2 years of age. 2% died in utero, and there were 6% for neonatal deaths. This looks at the results over here. You can see the three groups that they're randomized to in terms of delivery indication. This is the group where they had the best outcome, where they're waiting for late DV changes, so looking for an absent or reversed A wave for delivery. So in white, we have survived with no impairment. Here we have survived with impairment, and these are deaths over at the bottom. It's important to recognize, though, although they were randomized to delivery based on late DV changes, about a third of them were delivered for rescue computerized CTG criteria. Some of those were because of grossly abnormal decelerations, but others were based on short-term variability. So it makes it difficult to extrapolate this when we don't have CCTG available here for surveillance. There have been several experts that suggest that if you use Doppler and biophysical profile, it may provide the equivalent estimation of the delivery pH, and therefore maybe this could be used as a substitute for managing. That's basically how we're operating right now, but we do have to keep in mind that that has not been proven in a prospective randomized trial like CCTG has. All right, and then just quickly, the Porto study, they were trying to look at which sonographic findings were associated with perinatal morbidity and mortality and pregnancies affected by growth restriction. They looked at a number of different variables. They analyzed over 1,000 fetuses, and their conclusion was that abnormal umbilical artery Doppler and an estimated fetal weight below the third centile were strongly associated with adverse outcomes. Follow-up study looked at the cerebral placenta ratio, or CPR, and they found that if you had a CPR below 1, there's an 18% risk of adverse perinatal outcome, which was a 11-fold increase compared to cases with normal CPR. Okay, so we'll get into some management principles. So again, we have no effective antenatal treatment for placental dysfunction. So our management steps are fetal surveillance, so trying to prevent stillbirth and detect fetal deterioration, and then determining a threshold for delivery based on gestational age and severity of the findings, as well as maternal factors. As I've mentioned throughout this talk, the challenge is always balancing the fetal risk with the neonatal risk, trying not to deliver too early where neonatal complications may be higher, and then trying not to deliver too late when there is a high chance of fetal compromise or death. A lot of management in FGR revolves around trying to balance these risks, choosing intervals for monitoring to try to match disease progression, and to pick a delivery threshold that's proportional to the prematurity risk. So again, our primary goal is prevention of stillbirth and detection of fetal deterioration. And we've already talked about some of these tests here. So I'm going to skip over this, and we'll just go through some of the other aspects of management. Most of the recent guidelines that are out, which I will get to, talk about absolute delivery indications. So maternal preeclampsia with severe features, obviously there's a need for delivery in that situation for maternal safety. Grossly abnormal NST with repetitive fetal heart rate decelerations, absent variability, with late decelerations, bradycardia, or sinusoidal pattern would all be indications for delivery as well. It's also been reported that if you have a fairly low biophysical profile score, so a 0 or 2 or 60-minute score of 4, then you may want to consider delivery, as there's a high likelihood of fetal acidemia in that setting. Relative delivery indications, a lot of them are based on the cord Doppler. So if there's reversed and diastolic flow, then generally if you're over 34 weeks, you would consider delivery. It'd be 30 to 32 weeks was what most guidelines would suggest. With absent flow, it would be 32 to 34 weeks. The absent or reverse ductus venosus A wave, if you're beyond 26 weeks, that may be an indication for delivery. Below 26 weeks, you have to look at the entire context, how big the fetus is, and have a discussion with the patient and involve the neonatology service as well in terms of whether or not you just push forward or consider delivery at that time when the outcome may be poor. For mode of delivery, with early onset growth restriction, generally we push the pregnancy until we have late Doppler changes in the cord Doppler. If there are late Doppler changes like absent or reversed end-diastolic flow, the risk of needing a C-section for intrapartum complications is well over 80%. So in this situation, we'd recommend a cesarean section if late Doppler changes are present. With late onset growth restriction, the rate of vaginal birth was over 80% in the DigiChat trial. There are some models that look at some factors that may predict risk for needing a C-section. In this modeling, it includes an estimated fetal weight below the third centile, abnormal MCA Doppler CPR, or a low CPR. However, the positive predictive value at this time is not high enough to recommend a planned cesarean section in this group. So we generally say cesarean section would be reserved for usual obstetric indications with late onset growth restriction, unless there is another reason for cesarean delivery. For medical interventions, the only thing we really have to offer are steroids to promote fetal lung maturity, and magnesium sulfate for fetal neuroprotection at this time. Early onset growth restriction, we would recommend referral to a tertiary level center where MFM can be involved, as well as access to neonatal intensive care unit and neonatology. All the guidelines now recommend a uniform management protocol for monitoring and for managing growth restriction. And then we would base our surveillance on the clinical findings. Unfortunately, there is no consensus on monitoring frequency to help guide us, and that leads to a lot of variability in practice. The gestational age at delivery is the most significant determinant of survival, so in general, we want to push as far along as we can where we feel it's safe before we deliver. Late onset growth restriction is much more of a challenge, and there's a lot more controversy surrounding this. There is that association with adverse outcomes of low CPR, but there are no studies that kind of guide us on how to use this in terms of risk stratifying and guiding management or delivery decisions. So when the Barcelona group does a lot of research in growth restriction, and they've published several different approaches to managing small fetuses and growth-restricted fetuses, and they published a stage-based approach back in 2017 where they had a protocol in their unit where if the fetus was identified just to be SGA, they would do a Doppler and growth assessment every 2 weeks. If they were stage 1, and stage 1 for them was severe smallness, so less than the 3rd centile or mild placental insufficiency, they would do weekly monitoring and delivery after 37 weeks. With stage 2, where there's absent end-diastolic flow, they'd monitor twice a week and deliver after 34 weeks. Stage 3, with reversed end-diastolic flow or early DV changes, they would monitor every 1 to 2 days and deliver after 30 weeks. And with stage 4, where you have late DV changes, they would monitor every 12 to 24 hours, but essentially they're doing that while they prepare to deliver. This is just a little diagram of their protocol, which is a nice and neat little protocol. They recently published their 10-year experience for those that were diagnosed after 32 weeks, and they had just over 1,000 consecutive pregnancies that were identified. And in those that they classified as low-risk SGA, they actually would let them carry on to 40 weeks before being delivered, and they did not have any stillbirths in that group. That was about 619 pregnancies. There were 4 stillbirths in the growth-restricted group that occurred before 37 weeks. So again, this is a retrospective trial, not a prospective trial, but it provides some evidence in support of a protocol based on risk stratification for the management of the small fetus. So recently, there's been a flourish of guidelines that have been published. 2020, the International Society for Ultrasound Obstetrics and Gynecology published a guideline on management of the small fetus. The SMFM in the US published a guideline shortly after. And then more recently, FIGO published a very comprehensive guideline on fetal growth restriction. So I won't go through this in detail, but just want to illustrate their protocols that you see here. There's a nice little table in the ISHWAG protocol that's broken down by gestational age epochs in terms of what they recommend. A lot of the early management is based on the data from the Truffle trial, with delivery thresholds based on the Doppler findings at that time. There's much more variability when we look at the late onset criteria in terms of delivery. But essentially, most of the guidelines would argue that once you reach 38 weeks with a small fetus, there's likely no further benefit to carrying on, and so delivery is generally recommended between 38 and 39 weeks, unless there's other abnormalities that are seen or the fetus is quite small. SMFM published guidelines are actually quite different from ISHWAG and FIGO. For fetal surveillance, they only recommend looking at the umbilical artery and using an NST. They don't have any recommendations for looking at middle cerebral artery, CPR, or ductus venosus. So all of their management strategy is based solely on the umbilical artery and what the flow pattern is, and they base their management on that. Their delivery thresholds are fairly similar to the other guidelines, but their monitoring is quite different. And then lastly, there's a fairly comprehensive table in the FIGO guideline that I won't go through in detail, but it describes their suggested monitoring interval for low-risk SGA fetuses, uncomplicated growth-restricted fetuses, and then growth-restricted fetuses with Doppler abnormalities or other concerns, as well as including timing of delivery in that table as well. We can put that, when we put all of that information together from FIGO, they also have a nice little table that kind of looks at how to manage this pregnancy. So they have their absolute delivery indications, which are similar to what I had talked about earlier. They also include the CCTG criteria, since they have access to that in Europe. They then have their relative delivery indications over here, and then relative delivery indications below based on Doppler findings. So between 26 and 30 weeks, you'd have to have pretty advanced Doppler findings looking at the ductus venosus to trigger delivery. Beyond that, you're starting to look at the core Doppler and what the end-diastolic velocity is to trigger your delivery at different thresholds. Okay. So I do have just a quick comparison of the different guidelines. SMFM, they don't actually have criteria for antenatal diagnosis of SGA. They basically say that any fetus with an EFW AC below the 10th centile should be classified as growth restricted. Whereas Ishuag and FIGO have basically decided to follow the Delphi consensus that I talked about earlier in terms of classifying and diagnosing growth restriction. The Canadian guidelines are currently under revision. I'm not sure when they're going to be published, but the two of the authors that wrote the FIGO guideline are involved in writing the revised SOGC guidelines, so we may see some similarity there when they're published. In terms of monitoring, most of the guidelines recommend anywhere weekly to 1 to 2 times per week for low-risk fetuses. And then as you have progressive Doppler abnormalities, the frequency of monitoring increases. Again, important to know that ductus venosus is not recommended for SMFM. And then delivery criteria between all the guidelines are actually quite similar. And I've already talked about this a little bit, so I'm just going to skip over at the moment. So that kind of led to, or some of this led to us, or actually it was probably more COVID that led to us to decide to update our MFM protocol for managing a growth-restricted fetus. This is a work in progress that's continuously being tweaked. We are looking at this with the group in Vancouver as well as the group in Victoria as well. Essentially, what we're looking at now is looking at both the abdominal circumference and estimated fetal weight below the 10th centile in terms of diagnosing the small fetus, and then using comprehensive Doppler assessment to differentiate SGA from FGR. And similar to the other guidelines, we're then looking at management based on the Doppler findings, which is fairly similar to what we were doing before, except for the diagnosis and the classification aspect. There is a provincial guideline that we're working on as well. I wasn't going to go through this today because it hasn't been finalized, and we're still getting some input from the other groups and then from other stakeholders. But essentially what we're looking at creating is a document that's going to help work through a referral pathway and management pathway in the community setting, again, trying to differentiate the low-risk SGA fetus from the growth-restricted fetus. So for the future here, there is a plan eventually to roll out a new growth standard provincially using the WHO growth standard, I believe, and then reporting AC and EFW percentiles on ultrasounds that are done for estimating fetal weight and size. To support our medical imaging units to report umbilical artery pulsatility index, which is the standard that's used internationally as opposed to SD ratio. And then we're looking at updating a provincial protocol for management of the small fetus. So I know that's kind of a really long talk on growth restriction, and I know there's lots of other aspects that I didn't cover, and I apologize for going later than I anticipated. If there's any questions or time for questions, I'd be happy to answer what I can.
James, thanks very much for a very comprehensive and excellent talk there. Do we have any questions from the audience? Feel free to speak up.
Hi, James. It's Sarah Kaufman. That was a great presentation. I'm still getting my head around a lot. I think I've asked you this question before, but I wonder if you have an update on a lot of what you talked about with respect to what we have access to is around the BPP, the full BPP, and we have trouble with the community agencies providing that. And so we're doing modified BPP. Is there? Do you have a sense of if they come out with the provincial guideline, we'll have sway to have the community clinics provide BPP a little more readily?
Yeah, that's a tough one. Like I trained in an area where we were BPP friendly, and so I'm used to having them there. So it's been a bit of an adjustment not having kind of a fetal assessment unit where they're done at the same time as the NST. And I don't think necessarily all pregnancies need a BPP, but it's a really nice tool to have when you have that kind of atypical NST to provide you with some additional reassurance about fetal behavior. There's still, biphysical profile is mostly North American. I don't really know why traditionally it's not performed here, but there's still some controversy amongst our group about whether or not we should be looking at introducing it. So going forward, it might be something that's more done locally. I think it would be great if we had access to it as an additional tool provincially. I would prefer to have computerized CTG because I think there's more evidence for that, particularly in a randomized prospective trial. But I think the holdup with that, from what I understand, is Health Canada, and I don't think any North American sites that I'm aware of are using CCTG. So we're kind of left with, conventional NST with ultrasound findings. The modified biophysical profile is still robust, and it still can be used in place of a biophysical profile, which is kind of what's done here, just sometimes they're not done at the same time. They may be done temporally in different places and sometimes on different days. And so it's trying to put that information together. But I do think that there's still controversy about the biophysical profile, and there is some, it's hard to look at evidence in growth restriction because there's not a lot of great evidence in terms of prospective randomized trials, and that's where the challenge comes in with the profile. I do think, until we have something better, it's a useful tool. It's just another screening test to give us information about how this fetus is doing at this time instead of looking at just one factor like the NST alone. I didn't really answer your question. I would like to be able to offer it, but I don't know what's going to happen in terms of rolling it out.
No, that's great. Thanks.
I think there's a bunch of us that would like to have access to it, though.
Any other questions? All right, Dr. Andrews, thank you very, very much for speaking to us today, and thank you all for coming and joining us, and we will see everyone next week for Grand Rounds.
Your call will be disconnected.